Topics in Neurosurgery, written and narrated by Dr.Boyd. C1 fracture. C1, known as the atlas, lacks a vertebral body and spinous process. Instead, it consists of anterior and posterior arches that encircle the spinal cord and connect to the odontoid process. C1 fractures typically result from axial loading. The ring often breaks in two places. C1 fractures account for approximately 10% of all cervical spine fractures. C1 fractures typically present with axial neck pain without initial signs of neurological dysfunction, as the fracture fragments tend to be outwardly displaced rather than encroach on the neural canal. The spinal canal is also very spacious at this level. According to Steele's rule of threes, at the level of the atlas, the odontoid process, the subarachnoid space, and the spinal cord each occupy 1/3 of the area of the spinal canal. The overall prognosis of C1 fractures is favorable, with conservative management and external immobilization. Fracture of C1 is also known as Jefferson's fracture. C2 fracture. A hangman's fracture is a bilateral fracture of the posterior elements of cervical vertebrae 2, with an associated traumatic subluxation of C2 onto C3. Despite the term implying a hyperextension and distraction injury, such as the case in judicial hanging, the more common mechanism of action is hyperextension with axial loading with motor vehicular accidents and diving injuries. Hangman's fractures represent up to 20% of all cervical fractures. Treatment options include conservative management, cervical arthrosis, halo vest arthrosis, and surgical procedures. Clay-Shoveller's fracture. A Clay-Shoveller's fracture is a very rare occurring stress type avulsion fracture of the lower cervical or upper thoracic spinous process. This condition was considered an occupational injury mainly seen in laborers involving shoveling heavy loads. At present, it's most likely encountered in athletes or seen in recreational injuries. Surgery is not usually needed. Treatment is cervical collar to stabilize the neck and support healing, and NSAIDs to manage the pain. Atlanto-occipital dislocation. Atlanto-occipital dislocation is a ligamentous separation of the spinal column from the skull base. This can lead to compression of the spinal cord, resulting in potentially fatal consequences. The injury is immediately fatal in 70% of cases, with an additional 15% surviving to the emergency room but dying during the subsequent hospital stay. The injury is more likely in children. Chance fracture. A chance fracture is an unstable spine fracture resulting from a flexion distraction injury of the spine that typically occurs at the thoracolumbar junction. It's a horizontal fracture, extending from the posterior to the anterior through the spinous process, pedicles, and vertebral body. It's also called a seatbelt fracture, where there's sudden forward flexion and no shoulder harness. Patients rarely present with neurological deficit. However, the incidence of concurrent intra-abdominal injuries can be as high as 50%. Anterior cord syndrome, or ventral cord syndrome. Anterior cord syndrome is an incomplete spinal cord injury that is often related to flexion injuries of the cervical region that result in infarction of the anterior 2/3 of the cord and/or its vascular supply from the anterior spinal artery. Below the level of injury, there is bilateral loss or dysfunction of motor function and sensation. However, proprioception, vibratory sense, fine touch, and two-point discrimination are preserved due to the intact dorsal columns supplied by the posterior spinal arteries. MRI is the modality of choice for visual assessment of spinal cord ischemia. Central cord syndrome. Central cord syndrome is characterized by disproportionately greater motor impairment in the upper compared to the lower extremities, due to the more centrally located anterior gray column containing the motor neurons over the upper extremity. It usually results from traumatic hyperextension, which causes spinal cord impingement, leading to major injury to the central corticospinal tract of the spinal cord. Central cord syndrome most frequently occurs among older persons after acute hyperextension injury with cervical spondylosis. Treatment is conservative unless there's spinal instability. Motor function in the lower extremities returns earlier and more often than the upper extremities. Brown-Séquard syndrome is defined as an incomplete pattern of injury following a hemisection of the spinal cord resulting in weakness or paralysis, loss of proprioception and vibration sense on the same side as the damage, and loss of pain and temperature sensation on the opposite side. It's most often caused by trauma, with knife injury being the most common traumatic mechanism. Syndrome of inappropriate ADH. Water excretion is tightly regulated by antidiuretic hormone, or ADH. It's synthesized in the hypothalamus and stored in the posterior pituitary gland. ADH is released in states of increased osmolarity or volume depletion. Once released, ADH promotes water reabsorption by the kidneys. Inappropriate secretion of ADH, despite normal or increased plasma volume, can cause impaired water excretion by the kidney, leading to hyponatremia. Common causes of the syndrome of inappropriate ADH include certain cancers like small cell lung cancer, multiple drugs including antidepressants, and more importantly, surgery such as brain or bone surgery and disorders of the brain like tumors, stroke, or meningitis. Treatment options include hypertonic saline, loop diuretics, vasopressin 2 receptor antagonist, and fluid restriction. Central diabetes insipidus. Central diabetes insipidus is a result of damage to the pituitary or hypothalamus, leading to a defect in ADH secretion. This results in massive urinary output, leading to severe dehydration and hypernatremia. This defect in ADH secretion can be caused by pituitary surgery, closed head injury, or anoxic encephalopathy. The treatment of central diabetes insipidus is the administration of vasopressin, DDAVP, and replacing volume. Subdural hematoma. A subdural hematoma forms because of an accumulation of blood under the dura mater. Subdural hematoma has multiple causes, including head trauma, coagulopathy, and any vascular abnormality rupture. In head trauma, the bridging veins under the dura may rupture when direct opposing forces rupture their thin walls, releasing blood under the dura mater, forming a subdural hematoma. Definitive treatment is evacuation, but depending upon the size and location, some subdural hematomas may be monitored for resolution. Age younger than 40 years is associated with a mortality rate of 20%, whereas age 40 to 80 years is associated with a mortality rate of up to 65%. Epidural hematoma. Epidural hematoma occurs after blunt trauma to the head, typically the temporal region. A skull fracture with damage to the middle meningeal artery causes arterial bleeding into the potential epidural space. The classic presentation of an epidural hematoma is loss of consciousness after injury, followed by a lucid interval, and then neurologic deterioration. The characteristic imaging finding is a hyperdense extraaxial, lens-shaped, or biconvex opacity. Definitive treatment is an evacuation of the hematoma and stopping the bleeding source. The overall mortality for epidural hematoma is 10%. Basilar skull fracture. Basilar skull fractures, usually caused by substantial blunt force trauma, involve at least one of the bones that compose the base of the skull, most commonly the temporal bone. Most basilar skull fractures are caused by high-velocity blunt trauma, such as motor vehicle collisions, but falls and assaults are also important causes. Several clinical signs are highly predictive of basilar skull fracture, including periorbital ecchymosis or raccoon eyes and cerebrospinal fluid rhinorrhea in anterior cerebral fossa basilar skull fracture. Retroauricular ecchymosis or battle sign and hemotympanum are seen in middle cerebral fossa basilar skull fracture. The majority of CSF leaks resolve spontaneously within about 5 to 10 days, but some can persist for months. Meningitis may occur, but in less than 5% of patients. Brain tumors. Most brain tumors are metastatic lesions from the lung, breast, colon, kidney, or melanomas. Astrocytoma, which arises from the astrocytes, the star-shaped glial cells found in the cerebrum. Constituting 60% of brain tumors, glial tumors include astrocytoma as the most prevalent form of glioma. Magnetic resonance imaging is the best imaging modality for diagnosing astrocytoma. Surgical resection is indicated for low-grade astrocytoma and has a survival rate of 90%. Glioblastoma multiforme comprises glioma's most malignant and pervasive subtype and is the most common primary brain tumor in adults, accounting for 45% of primary malignant brain and central nervous system tumors. It remains an incurable disease, with a median survival of 15 months. Meningioma is a known benign central nervous system tumor commonly arising from the meninges of the brain and spinal cord. Most patients with meningioma are asymptomatic, and the management is usually close observation and follow-up with serial imaging. However, symptomatic patients usually require surgery to lower the risk of recurrence and the severity of the